email and type your email and organization name in the chat as a way for us to capture who is here with us today. The slides, forms, and any other materials referenced today are going to be available following today's call on the AIDPH website. We ask that in talking about cases or patients or other clinical information that folks remember to avoid sharing any protected health information or personally identifiable information, both on today's call and throughout the ECHO. And I'll talk a little bit more about that briefly. If you have any questions about the Zoom platform during today's call, please pop that in the chat. If you're able to do so, you can chat Annalise directly or chat something to the whole group. And I'm actually also going to ask our expert faculty who are with us, David Capelli, Caroline McLeod, Joni Nelson, and Bob Russell, to also chat in there so folks can see who you are. So some session norms that we're going to go over real briefly for today's session and all future ones. A core tenet of the ECHO model is that each person learns and each person teaches. And this means that we invite you and expect you to be inquisitive learners, to pose questions, and also to teach others, drawing from your experiences and expertise in the space. Another norm is that we're only going to use first names to facilitate equality in the discussion. So I know many folks have various doctorate degrees. We're not going to use those, but just use first names throughout. We ask that before you speak, that you introduce yourself with your name, organization, and location. We ask that you turn on your video throughout, but please keep yourself on mute until you're ready to talk. Please try to limit any environmental distractions, rustling papers, people walking behind you if possible. But we also acknowledge that some folks are at home, and that's just where we are right now. And please respect one another. It's okay to disagree, but we ask that you do so with respect. Next slide. I know that we're all familiar with respecting patient health information. We've called out on this slide, and I won't read it at all, but just to consider patient names, locations, dates, any information about their employment or any other identifiers that might reveal or suggest a patient's information when talking. If you have any questions about what constitutes PHI or PII, please err on the side of caution, and you can also chat Annalise directly for some guidance. So our call today, we are going to do a welcome and overview of the call. Then we're going to have a didactic presentation on population health, oral health program development for rural states by Bob Russell. We'll have some time for participant Q&A. We're then going to move into a case presentation from Jeanette Gomez with the Nevada Oral Health Program. We'll have a discussion of her case, and then we'll close out with next steps. So with that, I'm going to turn it over briefly to Annalise Cothran, the co-founder and executive director of AIDPH.
Hi, everyone, and welcome. Thank you, Stacy, for facilitating this call. We really just wanted to give you a little bit of background about AIDPH in case you haven't participated in any of our programs before. We are a 501c3 nonprofit centering health equity in the science and education of dental public health. And so as part of that, we look to develop professional development opportunities for oral health professionals in pursuit of our mission of fostering professional excellence. Our vision is an equity-oriented oral health workforce prepared to lead, which is why this ECHO program is incredibly important. We want to ensure that the oral health workforce has the tools that it needs to lead with equity. That's part of our mission. And I will stop there.
Great, thanks so much, Annalise. So I'll talk real briefly about what is an ECHO for those of you who may not be familiar with the model. So Project ECHO is a knowledge sharing network that's led by teams of experts who use a video conference driven practice model to empower and build the capacity of local health professionals and health teams. The ECHO model is committed to addressing the needs of vulnerable populations, largely by equipping communities with the right knowledge at the right place and time to make decisions that drive optimal outcomes. The hub and spoke model, this knowledge sharing network, creates a learning loop whereby community providers learn from specialists, the community providers learn from each other, and specialists learn from community providers as best practices emerge. And when we talk about providers, we're actually talking about clinical providers, but program managers as well, and other folks, other professionals working in the space. Each of the ECHO calls that we're going to hold includes an expert didactic presentation, participant Q&A, a case presentation, and then feedback from the group, both from faculty on the call and other participants, that's focused on problem solving and capacity building. AIDPH's Rural Oral Health ECHO has a number of, is based on the 3 domains framework developed by the CareQuest Institute using the lens of rurality and health equity. So those 3 domains are teleprevention, minimally invasive care, and integrated and personalized care. And I won't dive into all of these, but we'll make additional information available on the 3 domains framework for anyone who would like to learn more. And as the model implies, participants take knowledge back to their communities to implement in their daily work, building the capacity of the oral health professional workforce. We have a number of topics that are mapped out through the end of the year for this Rural Oral Health ECHO. So stay tuned for more information on these as we move along. I am going to read to you that the presenters declare they do not have a financial arrangement or affiliation with any corporate organization offering financial support or grant monies for this continuing dental education program, nor do they have a financial interest in any commercial products or services that they'll discuss. So with that, I am going to turn the microphone over to, excuse me, Bob Russell, who recently retired as the Public Health Dental Director for the state of Iowa's Department of Public Health, which he joined in 2005. Bob resides in Des Moines, Iowa, and in addition to his various dental distinctions, serves as Vice President of the Region 7 Head Start Association, the Board of Directors of the National Academy for State Health Policy, the Iowa Hawkeye Advisory Committee, and the Free Clinics of Iowa Advisory Committee. Bob, please take it away.
Thank you very much. I'm glad to be here. Can everyone hear me?
Yes.
Okay, very good. Once again, I have no conflicts of interest, so we can go forward. I want to start with just laying the foundation, the general definition of population health management, which each of you can read here, but I just want to make sure that we are following basically this idea as the framing of what I'm going to discuss with you today. Next slide. So these are the things that I feel that in my adventures in trying to increase population-based care, especially in rural communities, that we had to know. The data had to be available for us to have any way of making any planning. So what are the resources currently available? Workforce availability, provider licensing restrictions in your given state, level of technology and health record integrating potential. In other words, can you capture the data that you need? Policy changes that need to be implemented if you're going to move forward, level of commitment among broad stakeholders, population groups to be targeted, location, infrastructure availability, community leaders and cultural representation, funding sources and potential resources, and building relationships and creating purpose. These are the things that you need to have in mind when you start developing any kind of initiative focusing on what we call rural and overall global health within your given area. Next slide. So what I'm going to talk a little bit about is what we did in my state of Iowa, starting back in 2006, where we had to consider those things I just mentioned. This is a working example of population health intervention in oral health in the state of Iowa. Next slide. And so what you see here is that we started down a path of promotions, a lot of promotions. We developed a lot of flyers, a lot of videos, a lot of television ads, different things were put out in order just to educate the general population of the importance of oral health. Next slide. So we're going to talk a little about how iSmile began, what has happened, and where we are today. Next slide. So it started back in 2005. State legislation was passed that included the requirement that Medicaid enrolled children had to have a dental home. We had a collaboration with a number of stakeholders that began to look at what do we need to do in order to make this possibility work. We needed multiple providers. So we knew it could not be driven by dentists or hygienists alone, but it had to include the medical profession and others that would be able to play a role. Multiple locations were involved as well. Integrated services, where we had to deal with prevention care coordination and treatment education from different models. Next slide, please. So we had to deal with the fact that many solutions had to be brought together. Now, this is just a list of some of the things that we did. Expanding dental prevention educational opportunities, which I showed with the slide talking about promotions that we did. We targeted dental hygienists in public health settings as our workforce that would lead this initiative. Our licensing laws were amended to allow for this to happen. We were able to convince our board of dentistry to allow practice flexibility for hygienists to be to serve in this area. We also looked at how we would work with community-based workers. We also integrated with our WIC program, as well as our maternal child health and their various programs. The key thing is for iSmile is it was built on the back of maternal child health. We had 23 Title V agencies throughout our state that work primarily in rural communities. And we targeted those areas where we actually had hygienists hired on as oral health coordinators in those areas. We improved Medicaid and other benefits to make sure that we had funding to make this initiative work. We did a lot of going to different schools to help Iowa students to pursue dental education and encourage it. Student loan and scholarships for dental teams and training, that was also encouraged at the state level. And we really wanted diversity within our oral health professions. And we really focused on our rural and our community programs. Next slide. So framing the initiative as a policy objective was really, really important because we didn't have it. We had no real vision as to what we were going to do. And we needed to create that vision among our policy leaders so that the funding flow had a directive where it would actually get the outcomes that we needed. So policy is very important in order to frame the goals as we move forward. Next slide. So there came policy. We call it House File 841, which was very important. It's called the Iowa Care Act. And what it basically said was by July 1, 2008, every Medicaid recipient who's a child 12 years of age or less must have a designated dental home. I want to make clear it didn't limit to just Medicaid. It also included our Title V or the uninsured agencies as well. We kind of put it together as a package deal. And you can see our little logo on the left side there. That became our symbol everywhere with everything we put out. That symbol was in the front. Next slide. And so phase one was strengthening local public health systems, and that is establish the iSmile prevention and referral network within existing networks of public health agencies. We hired an iSmile oral health coordinator within each agency to oversee iSmile services, and we purchased necessary dental equipment as well as analytic capacity, as well as our software system that allowed portable laptop use where they would be able to tap into our statewide database and they would enter that data into our system. And that has improved over the years as well. We had a very simplistic model to start, but we've invested millions of dollars to increase that analytical capacity, which is much better today. Next slide. So this is just a little layout of Iowa. iSmile became an oral health component of the state's maternal and child health program I mentioned earlier, and there was these agencies throughout, or should we say districts, that had the Title V presence that we were able to marry our program into those operations. That included WIC. So WIC distribution centers also became a part of our iSmile network, as well as the Title V. So we were able to provide what we call overarching services and including dental services to that mixture, which really what made it robust. Next slide. So it's an integrated service delivery system, which I kind of mentioned. Early identification of dental disease became the primary goal. early prevention, utilizing dental hygienists where we could, strengthening parental involvement. Ultimately, at-risk children who are currently excluded from the dental care system would be identified and would have a dental home, which means attach them to a local dentist who would be able to provide services. Next slide. And so this is just some of the campaigns that you can see throughout the state and how we use our hygienists and how we promoted what we did throughout the state. And there are a lot more I could show you, but this gives you a good feel of what activities were occurring statewide. Next slide. So what has happened between 2006, when we first started pushing this around, in 2021? We got funding to local public health programs, which I mentioned through our policy initiatives and our partnership with Medicaid. Partnerships were developed, statewide infrastructure was built. It took time to do this, but that was something we were dedicated to do, and that policy, the window, allowed us that opportunity. So we built more prevention in public health locations. We did linkages with physicians and primary care practices. And the overall results of these efforts over time has been less tooth decay. Now I'm going to show you a series of slides that talk about data. I won't be to read all the data to you, but I want you to just know it's there for you to peruse in time. Next slide, please. So here we are. We're starting with data, what we've noticed over the periods of time over the years. Now, data shows both good and bad. In other words, some things didn't go well and some things went well. As you can see here, the number of children who saw a dentist did increase between 2005 and 2020. But you notice that the trend went downward a little bit in 2020. And I think you're going to see that among every state. The COVID situation really definitely set us back a little bit. But I want you to know it has not stopped anything. We are beginning to see those numbers go back up. We are recovering very readily. But I just wanted to show you here that look at the average cost of Medicaid that has occurred over the years from 2005 to 2020 per child. And you can see at ages 1, 2, 3, and 4, and 5, in 2005, $181.88 per child was the general cost for a 5-year-old. Look at 2020, it went down to $175.71. So there was a reduction in overall cost providing care because we put this community together. And the fact that we targeted these very young children was one of the great benefits because it obviously translates into later ages. Next slide. And so this is, once again, some of the summaries of things we've noticed. We really targeted various communities of racial as well as nationalities so that we could kind of do a good comparison of what's going on. And you can see, obviously, non-Hispanic other actually accessed, more likely non-Hispanic other had high levels of decay, as well as non-Hispanic Black compared to Hispanic, and then of course whites. That's the very general thing you can see throughout probably the entire nation. But what we are seeing is that 77% had dental decay, which improved from 11% in 2010. So this is the good news. We're making a dent. And I think that really has a very good thing. And you can see other statistics here that show that we're beginning to see more and more kids and things are beginning to happen at a very good level. Next slide, please. Once again, we're seeing the dentist's willingness to bill Medicaid increase because we had that outreach program at the local level. You can see 2005 where it was, look at compared to the 2010, and 2015 was a slight slip, but then you look at 2020, once again, we're dealing with the COVID situation. So we expect those stats to go down. But look at the number of children 3 years of age receiving fluoride varnishes. And well, notice how more of them are getting fluoride varnishes because of this program, because we have these local groups of hygienists along with other team members, nursing and other groups who are providing these fluorides, as well as the physicians who are beginning to come on board. And you can see even in 2020, more physicians were doing fluoride varnishes than years prior. So that was a good sign. Next slide. This is just a slide that just talks about why we were able to make the case, why we were able to get policy promoted, why we're able to get interest in what we're doing is because there was a lot of data showing us how much cost this was costing the state if we did nothing. So that's very important to understand. The fact is that dental care, especially on preventable dental care, especially untreated dental care, does cause a lot of costs to our hospital system. It's very, very important, in other words, and that's why we think that the strategy is very important. Next slide, please. So where are we today in 2021? Well, number one, we're adapting to changes. As I mentioned, our money has been put into data collection. We've got a much more sophisticated software system than we ever had before. Our ability to analyze data is really, really great compared to what it used to be. And that's always an ongoing improvement. So to understand that happens. We do have issues though. There's still disparities in families of color, which we're beginning to identify some of those small pockets and those organizations that can help us reach those pockets better. That is something that's happening right now. We're seeing a growing crisis with dentists not taking lower income patients. We're seeing dentists actually complaining about our Medicaid rates in our state, which has to be addressed. The cost of health care, or the cost of the health system is always a big problem. And then there are adults who cannot afford care. So it's not enough just to focus on children. So we've created a new program called iSmile Silver, which is an extension of where we plan to go to include the entire family in all age range. Next slide, please. So what's our real focus? Is it dental home? Well, in a way, yes, but should we be talking about oral health instead? These are the things I think we need to focus on. Our population-based approach, to talk to people, to find out what their experiences are, and then to begin to apply interventions that work with them. And to help coach them. So you can see that's what this slide is kind of telling us. That's the way we're gonna move this going forward. Next slide. So iSmile Silver, it's a pilot. It's beginning to start. There are about 9 counties covered right now, but it's age 21 and above, which means it takes our iSmile system even further. We started out at age 61, a group of 61 in retirement, but now it covers all ages over 21. Next slide, please. So our goal is simply to address disparities, improving data collection, health equity training, and work with partners. We want to use data to illustrate linkages and build linkages between primary care and dental providers. We want to improve our access to dentists. So that will mean that we will be looking at some Medicaid modifications going forward. Affordability of care, that's going to be always an ongoing situation, trying to get people enrolled in Medicaid and Medicare, as well as to address the needs of the uninsured, which is a part of this program, which I'll be happy to talk about later on. But just let you know that the program is really robust right now. It is a statewide initiative, and we do have strong political backing to continue moving in this direction, regardless of the political persuasion. Next slide, please. So success for us would be all Iowans are able to receive dental care regularly and when needed for treatment beginning at birth. We want all Iowans to understand how maintaining optimal oral health and adopt positive behavior changes. We want Iowans to adopt new approaches for dental delivery system. In other words, new workforce models are possible under this system. Iowans understand the importance of oral health for overall health. I think those are the key messages we want to give and continue to promote. Next slide. So, and once again, the key thing is to adapt to change, because there's always change. Nothing stays static. So you will always have to face new challenges coming your way. And so our goal is to try to be able to be adaptive, keep the program vital, despite the fact we see ebbs and flows in policy and funding and a number of different things that are coming down the line. But that's really where we plan to move the program going forward. Next slide. So what can you do? This is just simply our message we make to all people within our states as to how they can assist to make this program more robust. And these are things that we put out in various different ways to get people engaged. Next slide. So if there are any questions, I'll be happy to take them. Thank you.
Thanks so much, Bob. So we do have one question in the chat. Does Iowa have Medicaid expansion, which allowed for iSmile Silver to provide care to persons 21 and older?
I wish I could say yes. We do have Medicaid expansion, but none of those funds are going into iSmile Silver. These programs are being funded by federal monies.
Okay. Any other questions? I think we have time for one or two questions.
Yeah, I put a question in the chat as well. So Bob, I'm wondering what your approach was to the dentist to entice them to treat Medicaid patients, because the reimbursement rates and the admin requirements are often the two biggest barriers there.
You're absolutely right. And they're difficult to address. One of the things we said about this program at the beginning is that, many dentists complain about no-shows. No-shows is a real big cost loss or funding loss to dentists. So we said, we're going to partner with you. These coordinators are going to actually handhold those patients that we refer to you and make sure they make their appointments. We're going to use the entire Title V Medicaid infrastructure to make sure that happens. We have cases where we're actually transporting those patients. If the parents are out in the fields and can't work, can't get off, we're going to get those kiddos and get them in. So those are the kind of things that are happening. We work directly with the provider to deal with their concerns. We deal with any conflicts in the Medicaid policy where repeated visits cannot be paid because some other providers providing it. We got rid of those barriers. So we've been really working hard to make sure that Medicaid is a good partner working with providers going forward. We've not been able to address the funding issue just yet, although right now, as I left the state, that is high priority for this year's legislative session. But that is something that we've got to do in order to get dentists to feel more comfortable. But because we did what we did, we were able to get a number of them involved.
Great.
And Bob, can I
Go
just ask really quick as a follow-up? When you started getting data in about the success of the program, did you see dentists more willing to participate after they could see some tangible results?
The answer to that is yes and no. The yes side is dentists felt supportive of the program. There was more public support by dentists and organized dentistry for it. Although I hate to say it, internally, there wasn't a lot of interest in it because the big problem is they didn't like Medicaid and they just simply didn't really feel like that was a big priority for them. The good news is I think they felt embarrassed enough not to be supportive. That it would look very, very poor on them if they did not. So the good news is that, yeah, I think there are those who really, really are good and they help a lot, and there are those that just never will.
Thanks.
Thank you. And then our final question before we move on to our case presenter, David.
Thank you, Stacy. Bob, thank you. Great presentation as always, and I enjoyed learning about this your programs. But I have a question. One of the issues that we face in now I'm in Nevada, and before I was in Texas and faced them in both states, is the lack of dentists in rural areas. And so when you're looking to identify a dental home or provide comprehensive care for patients, it's problematic because patients may have to drive 6 hours to find a dentist. And so how in Iowa did you overcome or address some of those issues?
Well, we work very closely with Delta Dental of Iowa, and they have a very nice foundation. And what we've done is we've actually have a scholarship program that targets graduating dentists out of our University of Iowa system and other local universities where they train dentists. And we actually provide startup money for them to start practices in rural communities. We target communities that we know are underserved, that do not have dentists within like a 30 or 40 square mile area. And Delta's money has been used to pay back loans and to work with the community resources so that practice can be established and the loans are paid off. And that has been very beneficial at targeting, shall we say, specific rural communities.
Great.
Thank you.
So I think there might be a couple other questions coming in. I'm going to just put a hold on those for now. If we're able to come back to them at the end, we will. And if not, we'll get folks' questions answered electronically after the session. So with that said, we're now going to turn to the case presentation part of today's program. And we're going to hear from Jeanette Gomez, who's been a registered dental hygienist for 11 years. Jeanette's clinical focus was working in periodontal offices and working with Medicaid populations. She continued her education to receive a BS with high honors in a specialty track for public health in 2018. Her passion for dental public health led her to apply for the state public health dental hygienist position, which she began last month, I believe. Jeanette is currently enrolling in the MPH program at UNR to continue her education. And I'm going to ask, before I turn it over to Jeanette, for folks to keep questions in mind as we go throughout. And we're also going to hear some specific questions that Jeanette has for our group. Take it away.
All right, thank you so much, Bob, for that presentation. I feel like I've already gained a lot of very helpful information. As Nevada's state public health dental hygienist, I would like to see Nevada develop the 2022 oral health state plan that focuses on rural health. The aim is to have an oral health program infrastructure and capacity to enhance and expand oral health program abilities to fulfill the goal of achieving optimal oral health in Nevada. This has been a challenge with a lot of the points that you brought up, Bob: limited funding, appropriate staff capacity, consistent and strong internal and external support, and sound planning. So I would really like to focus on bringing the continuation of health benefits after initial funding ends, especially in the rural areas. I want to gain trust in these areas so that they can count on the Nevada Oral Health Program to be there for them to continue providing these services. And as well as the program activities, I'd like to bring a lot of education to these rural areas. And I just want to ensure that we can sustain this for the long term. We had an oral health plan written in 2004, and we've had several surveillance programs that we've done, but it's fragmented. We'll do a surveillance program and then there won't be one for a few years. So I'd like to just keep things consistent so that we can apply for more funding and be a strong program. So my questions for you guys are: what facilitators are most effective in promoting the sustainability of a state oral health program, particularly that those can be considered in the program planning process, because that's where we're at right now? What program workforce capacity is needed for such sustainability?
Thanks, Jeanette. And I was just copying and pasting so I can put the questions in the chat. Oh, you got me, Annalise. Thank you. She's one step ahead of me, 2 steps ahead of me. So before we turn to the questions that Jeanette posed, I want to ask the group, do you have any clarifying questions for Jeanette to understand what challenges she's facing and what she's seeking from us?
Matt,
Okay.
I have a clarifying question. Oh, I'm sorry. I asked the other hands raised. Stacey, I'll let you go with that first. I'm sorry.
Okay, give me a second. I think, Annalise, could you stop sharing so that I can see all the hands that are being raised? Thank you. Okay, Celeste, do you have a question or a suggestion for Jeanette, or is your hand up still from Bob's presentation? Nope. Okay. Does anyone else have a question? I'm not seeing any other hands raised. David, or is that left over? You're on mute.
Sorry, yeah, I do that often. It's my new hand. So I have a question for Jeanette. Could you please outline a little bit about the oral health workforce so that we better understand the capacity that exists right now in Nevada?
As far as the public health workforce for the Nevada Oral Health Program, right now we have myself, it's a part-time public health hygienist position, so 20 hours a week. There will be a dental director hired in April, which will be a full-time position. And we have the public health endorsed dental hygienist in Nevada, so they can get their certificate to go practice public health as long as they're associated with the program and that dental board approves of that.
And I have a follow-up question as well. I'm sorry, I won't ask any more after this.
No, that's okay.
So could you share a little bit about partnerships within the state oral health program that you may have developed, maybe with, as I remember in Bob's presentation that he formed partnerships with the Maternal and Child Health Bureau or the Division of Epidemiology and Biostatistics, or any of those. Have you formed relationships with any of those partners? And I know that you've been here like a month and a half, so understanding that you're very new.
Yes, we're starting from scratch here, and I'm definitely looking into the MCH program. I'd love to correlate with them. So, and that was one of my questions for Bob, is how did you approach them to ensure that they'll give us the attention and that we can work together to help maternal child program. We have the Coalitions of Nevada, the Oral Health Nevada, Community Coalition for Oral Health, the dental hygiene schools are always so supportive with anything that we want to go and help out in Nevada. So I'll take any suggestions for key partnerships that would help the program.
Any suggestions from the group for Jeanette?
Question for you, Jeanette. So how is your sort of coverage of FQHCs in your state? The reason why I'm asking is because in Oregon, they serve all three healthcare populations, so behavioral, dental, and medical health, because that's the only place people in rural areas go. Is that a viable sort of systemic partnership that exists for Nevada to make more use of them?
Yes, definitely. We have one here in Northern Nevada, Community Health Alliance with Dr. Collier, and they provide dental as well as primary care. Southern Nevada has a clinic as well, Nevada Health Centers. But I think we need more in more of the rural areas of Nevada. And then Dr. Campelli, I don't know if you can elaborate on that. These centers I mentioned are in very populated areas. They're not really reaching the rural areas that need the help.
Yeah, this is a very oddly constructed state. So the population centers, even the rural centers, I mean, the sort of the center of the state, if you look at Nevada, the center of the state is really a lot of federal land. Although people do live in those areas, most of the population centers are in the urban areas, there are two in Nevada, and then rural areas. There are FQHCs. There are only a few FQHCs. One is other than the ones that Jeanette mentioned, there's one in Elko as well, associated with Nevada Health Centers that she mentioned, and they have also one in Southern Nevada. So it's a huge challenge, and there are dentists who practice in rural areas, but oftentimes they don't accept Medicaid, and so that's another barrier for access to care. So there are a lot of conflicting issues going on, and I know, so probably I'd be interested too in your perception of how Oregon has managed sort of to do that, to be more effective in accessing or providing services to the rural population. We just don't have the infrastructure in the state.
It looks like Zil had a question first.
Go ahead, Zil.
Sure. So I'm just kind of wondering, because I'm still more on like a policy oriented field when it comes to oral health. I know that the Nevada legislature in the 2019 session expanded dental hygienists and dental therapy practices. Have you seen any of that funding trickle down? Have you seen any of those programs showing any sort of dividends or results? Or has that sort of just kind of been a bust and mainly performative in its nature? What have you seen on that front?
The dental therapy program is still in the process of being approved by the dental board. So we don't have dental therapists out there yet. The public health endorsed hygienists, I think, is a very valuable group, but we need to reach these hygienists and motivate them to help the Nevada oral health program, possibly by volunteering, but they need to be associated with the program and be approved by the board as well.
Yeah, so some of the different things that I've seen in various states is once the state legislature and the dental board clear over the hurdles for those models for dental therapy, usually you start to see a few more individuals willing to work in the more rural centric areas. For example, I'm sure some individuals from Reno might take the trek over to West Wendover on the more eastern side of the state to make those leaps and jumps where there's already some sort of FQHC already in the state where you can loan someone for some period of time. I know that that's really very niche, very specific, but hoping to see if those duplicate once those clear hurdles would probably be a good resource barrier and advocacy perspective of getting those programs more readily available and thorough. And I don't know if I'm just like regurgitating the wheel here. Like,
no, that I agree. I completely agree with that.
Great, thank you. So I think we're going to connect Christian with David after the session. I'm going to now call on Corey, who has her hand up.
Thank you. I was wondering a little bit about what your scope of practice is for the dental hygienist. Okay, so you have a public health hygienist. What is their scope of practice? What can they perform? Are they under a dentist? Are they under the public health identity within your public health program of Nevada? And what billing is there a billing barrier? Do they have to be under a dentist that has to bill through them? Just a little bit about that.
Yeah, so the public health hygienist, myself, and whoever gets the endorsement, we can do screenings, fluoride varnish, education. I believe we could do some cleanings if the board approves. And as far as the billing, and Dr. Capelli, correct me if I'm wrong, but I believe that we can bill Medicaid for those services.
Yes, that's correct. Yeah. Thank you.
Great, Corey, does that answer your question?
I was just wondering about sealants for a prevention,
Yes,
preventive.
I forgot to mention sealants, yes.
How about SDF application?
Yes, I believe so.
Okay, thank you.
Great. So Annalise, do you want to pop in with a question, or you've had your hand up?
I do. I'm really curious about, Jeanette, what you mentioned in the beginning about gaining trust in rural communities. And is that something that you're looking for ideas around? And how do you feel like, is there a reason why you don't feel like trust is there? Or is there anything that you feel like trust needs to focus on when it comes to care implementation or maybe community assets? I'm really curious about that comment you made in the beginning.
Yeah, I've been doing a lot of reading about sustainability, and I think the Nevada Oral Health Program has done so many great things for our rural communities, but they're not consistent. And so I would just like these communities to be able to count on the oral health program for these services and know that they have somewhere to go to. And like I said, I'm pretty new to this program, so I'm not 100% on the history of the program, but I'm learning as I'm going. So that's kind of where I was going with the trust. It's just just so that Nevada knows that the oral health program is there for them.
I can speak a little bit to, we talked at the beginning about partnerships and then that trust piece on my experience. I'm in North Carolina. So the oral health section in North Carolina, which I have a little bit of experience there. So from a program planning perspective in North Carolina, the oral health program does have program specific partnerships with maternal health, so similar to what Bob said, public schools, and then facilities with individuals who have intellectual and developmental disabilities. So that kind of reaches across the lifespan in our state, which has been really interesting to see. And then basically dental hygienists work with these populations, and they really are the key workforce that we've seen in North Carolina make a difference. And the hygienists, they actually are located, so they live in all areas across the state, so urban and rural. And they work with those specific populations. And I've seen, since the hygienists live within the communities they work, they've actually been able to build trust within their communities, which I think has also been a key that may be helpful for you as you program plan. And I will say too, just as a note, with the pandemic, I actually think it's been so amazing to have the communication across the state among hygienists be even better because we've really learned how to communicate virtually. And so I would definitely encourage you to use what you've learned and your program has learned during the pandemic to communicate throughout the state with your hygienists.
Thank you.
Great. Dana, you had your hand up.
Hi, good afternoon. I'm with UPMC for You in Pennsylvania. I'm in a very similar position now as a public health dental hygiene practitioner. We work through the health plan. Have you tried anything through any of the health plans at all?
Yes, the program before I got in here was very close with Liberty Dental, which is our health plan, and they have been so helpful. So we do have a good connection with them and partnership to continue that.
Great. We have 14 public health dental hygiene practitioners throughout the state of Pennsylvania. And we actually are kind of our work base, or we work through Children's Hospital of Pittsburgh. So we work through the director of dental there. You know, so whenever we do submit claims or whatever we do, it's all in his name, basically. But we are all assigned different regions within Pennsylvania. So it really does help. And a lot of us are in rural areas as well. We do find a lot of these same issues, you know, that we are facing also. So it has been a challenge, you know, finding even providers, finding providers with sedation, you know, without having to go. I'm in Erie, so it's up in the northwest corner. And most are going to having to drive 2.5 hours to Pittsburgh in order to do a lot of the sedation, you know, cases as well. We do partner with a lot of the task force, the dental task force throughout the state and within our local regions. We also partner with a lot of the LICCs, you know, the coalitions, you know, in our areas as well. The Pennsylvania Coalition of Oral Health has been a huge help for us as well. So yeah, there are a lot of opportunities, you know, a lot of different things. We do partner with the schools as well and do some, you know, they help us out with some things. It's wonderful to hear that this is happening in other states, whether it's Iowa, you know, North Carolina, you know, wherever. So it's great. So I do commend you for, you know, for your work. It's wonderful.
Thank you. Thank you for that feedback.
Thanks, Dana. I'm going to call on Sherry and then on Zill.
Good afternoon. I'm Sherry. I'm from the North Dakota Oral Health Program. And I just want to really encourage you, Jeanette, to really dig deep into the why you're not getting the support that perhaps the dental community is providing. And also be curious with outside entities such as your faith-based communities, WIC, like Bob had also talked about, just thinking really outside the box of who could support you, what are they doing in oral health, and how can you help them along the way with what initiatives that they're doing as well. And really that trust piece, it takes time to build. I know here in North Dakota, we have, it's really rural, but we have tribal health liaisons that are within our health equity department. And I reached out to them to ask if they could help support the oral health program with connecting to those tribal health leaders within those communities so that we can build a relationship and I can learn what their needs are and how to help them, whether it would be oral health or it's diabetes or whatever, then I can find those resources for those community members. Another good resource for me, because I don't have a dental professional background, really connecting with the ASTDD group, the National Association of Chronic Disease Directors, for assistance as well. North Dakota was able to have the first ever oral health state engagement meeting, which helped me professionally, because then I learned more about my state and the dental background pieces, but also we brought a whole bunch of partners, medical, school systems, Head Start, you name it, to the table to talk about how can we work together to improve oral health in North Dakota. So if you ever want to reach out to us, you're more than welcome to, and I'd be happy to talk with you. So good luck.
Thank you so much.
Thanks, Sherry. And then we have like 2 more minutes. I'll call on Zill.
Sure, and I can make my statements pretty quick. I was just going to say here at NRHA, which is the National Rural Health Association, we do a lot of like advocacy work in like the workforce development in a pipeline situation. I know that UNLV has a like very strong front-facing pages and focuses on getting dental workforces, and I think they have like a remote campus in Winnemucca, if my memory serves me correct, but trying to maybe run down the avenues of the difference between UNLV's very specific dental program versus UNR's very specific medical program, which could help get into those inroads within the state. That's just my last kind of comment on that one.
Thank you, Zill. And thanks to everyone who's been active in the chat. As I just wrote in the chat, we're going to be sharing all the resources and suggestions that came up on today's call in a summary document, not only with Jeanette, but with all of you. So be on the lookout for that. It's great if you took some notes, but if you missed anything or couldn't write quickly enough, we'll have it in a summary document for everyone. So Annalise, could you take us back to the slides? So first and foremost, before I even go into next steps, I want to express a heartfelt thank you to Bob, to Jeanette, and to the rest of our hub faculty for being with us today and preparing for today's call, and also to all of you for really being the active learners that we hoped you would be. So thank you. This is a model that we're going to use carrying forward, and we will welcome your feedback as we go along. CEUs are available for today's session. We're going to send that information out to you following today's call with an evaluation and a request form. We're also going to make available recordings and resources from today's call on the AIDPH website. The next, and I shared that already, that we're going to be pulling together the recommendations. The next Rural Oral Health Echo session is going to take place at the end of March. It has not been scheduled yet, but please be on the lookout for information with that date and time. Lastly, we welcome anyone on this call and others you might know to submit a case form if they would like to present a case on a future Echo call, and we'll make those available to you as well. Anything I missed, Annalise, or anyone else? Okay, well, with that, I want to thank you all for being with us. Wish you a happy Monday. We appreciate your sharing part of it with us, and we look forward to being with you in the future. Thanks, everyone.
Thank you.
Take care.
Hi, Graylin. Jeanette, we ended the session too, so you can feel free to hop off if you want
Okay.
to.
Thank you so much.
Touch really soon a list of recommendations for you. Hopefully it's helpful. I hope you found some value today.
Thank you very much. Have a great day.
See ya. Hey, Graylin, is there anything that let me stop